Yes, we do. I would say not nearly as much as we do for ICL. So since we do corneal refractive surgery, we have patients who, with their initial topography, will have a little bit of a pattern called inferior steepening, where it's not like absolutely this disease called keratoconus, and those patients should not have refractive surgery, corneal refractive surgery, but it's almost just a hint of it. They'll be sent in to our central Denver location to get epithelial mapping to rule them in or rule them out for refractive surgery of that sort. Yeah, and yeah, it's been super useful for that. And so if it doesn't read it as high risk for keratoconus, then we'll proceed a lot of times with PRK instead of LASIK. Yeah, it's been super useful. We've used it for things like an IOL that, with like, let's say a person who complaining of glare and not great vision, like on exam, maybe a little tilted, but it's unclear if they're tilted. Then we've done the imaging, and we'll see that the lens is like half in and out of the bag, and it's not obvious because their pupil was very small and couldn't dilate more than that to really show the full picture. And so then, that was a colleague of mine, his patient, and he was able to then put in a pupil expander and say, yes, that lens is not not level and not in the bag. And so he was able to get it into the bag. And of course, 2 days later, the patient's like, you fixed it, So that was a really great case because the pupil was so small, my colleague was just unable to really appreciate what was going on. But, you can bring the patient back to the operating room and sometimes maybe go in there and everything's fine. So you don't want to put the patient at risk for intraocular surgery and infection just to look.
Right.
ArcScan was like able to show us, so that he was like, okay, you need to go into the operating room because I need to put this back in the appropriate position. Insight 100 frankly takes longer, but it's worth it.
Right.
And as far as workflow goes, I see a patient in original consultation to just know what their prescription is. They can't have too low of a prescription because there's the lowest number ICL prescription is a -3. And so they can't be like a -1 or something. That person should have corneal refractive surgery. I need to look at like the total health of the eye. I'm not going to implant an ICL if they have certain eye diseases like uveitis, glaucoma, bad retinal disease. I've had patients who have had sort of undiscovered issues with their retina that I had them get repaired first. Everything's stable, and then they've come in and gotten their ICL surgery. So I do this like very, very strict health check, and that makes them a candidate. We do there's some measurements that they have to be within. Their eye can be too small or too big actually for an ICL.